Our next speaker will be talking about nutrition in critically ill trauma patients. Dr. Lim Jia-Yan is a consultant of Department of Anesthesiology, Intensive Care and Pain Medicine in Tan Tock Seng Hospital, Singapore. She's accredited in anesthesiologist in intensive care medicine in Singapore and a European diploma in intensive care medicine and a graduate in diploma in palliative medicine.
Good evening, everyone. Thank you for taking the time to join us this evening. I thank the organizers for inviting me to give this talk on nutrition in critically ill trauma patients. I have no conflicts of interest to declare, and these are the objectives that we will be going through tonight. So let's start with why should we be feeding our critically ill trauma patients? So the injury sustained from trauma actually results in an acute phase response from the body, causing an immediate cardiovascular response, followed by an inflammatory response and a metabolic response. The metabolic response causes a hypermetabolism as well as catabolism, causing hyperglycemia, insulin resistance, and increased protein breakdown. So Paul Wischmeyer, in a review article, actually describes the body's response to injury into a three-phase approach. So one is acute, then next is chronic, as well as a recovery phase. And in the acute phase, he describes that the body's evolutionary metabolic response to injury is rapid catabolism. This actually provides energy to allow the key organ system to survive. And so our goal to feed the patient is actually to provide protein resuscitation in the acute as well as chronic and recovery phase. This is to minimize the effects of catabolism, to minimize loss of lean body mass, maintain muscle function. It can also help to aid wound healing as well as to enhance the immune function. So how then should we feed our patient? We'll just look through the guidelines as well as the evidence for it. So looking at time to initiate when do we want to feed the patient, if we look at the American guidelines, they suggest that similar to other critically ill patients, early enteral nutrition with a high protein polymeric diet should be initiated in the immediate post-trauma period. And early is defined as within 24 to 48 hours of injury. So this is actually endorsed by the European guidelines. And the European guidelines actually described further specific groups in which you wouldn't want to start enteral nutrition, early enteral nutrition. So some of them include patients who have incomplete resuscitation, patients with bowel ischemia, as well as patients with abdominal compartment syndrome. To note, the quality of the evidence has been graded as very low because the evidence can be quite conflicting at times, and a lot of the recommendations is actually by consensus by an expert committee. So if we look at the meta-analysis done in the American guidelines, we can see that there is actually mortality benefit to feeding early, as well as less infectious complications if we feed patients early. However, the studies that were included in the meta-analysis earlier includes patients from a heterogeneous ICU population. So looking specifically at trauma patients, Doug et al. Did meta-analysis, which included a few studies, although they are a little bit old, and they also did find that there was some mortality benefit in feeding patients early with enteral nutrition in trauma patients. Okay, and delayed feeding itself can also cause problems. So in this study that was done in Australia, they actually wanted to look at intestinal absorption of glucose in patients who were fed within 24 hours, or they were being given feeds 4 days later. And as you can see from the graph on the right, you can see that in the group that has delayed enteral nutrition, the intestinal absorption of glucose is actually much less. And they also found that the group which had delayed enteral nutrition also had increased mechanical ventilation as well as longer ICU length of stay. So where should we feed? Should we give our patients enteral feeds or parenteral feeds? And is there any problem with giving parenteral nutrition? So from what we can see earlier, enteral is the route that is recommended in most guidelines. other than delivering nutrition, there are actually a lot of non-nutritional benefits of enteral nutrition as well. So it helps to maintain the gastrointestinal tract structural integrity as well as gut perfusion. It can help to preserve the gastrointestinal associated lymphoid tissue, which helps to maintain the immune function. It can improve gastrointestinal motility. However, this is predominantly in the setting of major burn injuries, as well as acute care surgical patients. And again, if we look at the meta-analysis in both the American and European guidelines, we can see that there are reduced infectious complications in both the meta-analysis that were done. But if you note in the European forest plot, we can see that studies that were included are newer as well as larger. And the pool estimate has actually shifted a little bit to the right, nearer to the line of no effect. And we will elaborate a little bit on this later on. A specific group of patients that I wanted to touch on are patients with an open abdomen. So patients with an open abdomen, there's always fear that the patients may have ileus, bowel edema, and most people don't feed them, at least in our local center. But actually, in the guidelines, they actually do recommend early enteral nutrition for these patients as well. There have been small studies done, mainly 2007, 2008, where there was some benefit in terms of early abdominal closure, reduced pneumonia with enteral feeding in patients with an open abdomen. So this is actually one of the largest studies done in 2012, although it's a retrospective study, and they looked at patients with an open abdomen who were being fed enterally versus no feeding. And they actually divided patients into patients with enteric injury versus patients with no enteric injury. So we can see that patients who were fed enterally, ultimately more of them had definitive fascial closure. But when we look at the time to closure, they actually had a longer time to closure. And if you look at complications wise, total number of complications were actually higher in patients with enteral feeds. But if you look into the subgroups, if you look at those with no enteric injury, the difference is actually not very much. And the difference you can see mostly came from the patients with enteric injury. And so the authors actually felt that enteral nutrition is feasible for patients with an open abdomen, but more so if there is no bowel injury. And both the East as well as Western Trauma Association also recommend early enteral feeding for patients with an open abdomen. And they do recommend that in patients with open abdomen, there's lots of fluid loss, protein loss, and they may need a higher protein prescription in their nutritional prescription. Fortunately, at least in the local context, we can see that the most common injuries are in the head, as well as upper and lower limbs and thorax region. So most of our trauma patients should actually be able to tolerate enteral feeding. Okay, and we have looked so much at enteral feeding itself. What about parenteral nutrition? Is it all that bad? Is it like condemned? So some of the newer studies that looked at enteral versus parenteral nutrition. So this is the CALORIES trial. It was done in the UK to determine if parenteral nutrition was superior to enteral nutrition in critically ill adults. And patients were given enteral nutrition or parenteral nutrition for 5 days with a target of 25 kilocalories per kg per day. We can see that the energy goals were actually not met in both groups, more so in the enteral group. The amount of protein given was also less than recommended in the guidelines. On the graph to the right, we can see that less than 50% of the patients actually had their caloric target met. And most of them who had their target met were actually in the parenteral group. So in this study, they actually found that there was no difference in terms of primary outcome, which is mortality, as well as infectious outcomes between the groups. But they did find that the group that had enteral feeding had higher gastric residual volume, more episodes of hypoglycemia, and more episodes of vomiting as well. So the conclusion was that parenteral nutrition was actually not superior, but not inferior as well to enteral nutrition. And it actually showed us that in the pragmatic trial, we are often not meeting our feeding targets. Another trial that was done to compare enteral as well as parenteral nutrition is the Nutria 2 study. So it actually also compared early enteral nutrition versus parenteral nutrition in ICU patients with shock. They found no difference in mortality. You can see over here. But they did find that patients who were fed enterally had higher risk of bowel ischemia, as well as acute colonic pseudo-obstruction. The limitation of this trial was that it was actually prematurely discontinued because the interim analysis actually showed that the outcome was not going to change with further recruitment. But again, we can see that enteral nutrition was not superior to parenteral nutrition and probably should be avoided in patients with shock. So why is there a difference between the older studies as well as the newer studies? So in this review article by Kagan and Singer, they actually feel that complications related to parenteral nutrition may be related to caloric load. And overfeeding with parenteral nutrition, probably seen in the older studies, could have resulted in hypercapnia and respiratory insufficiency, hyperinsulinemia, azotemia from excess amino acids. And in some of the older parenteral supplementation, or at least the parenteral formulations, they contain soybean-based lipid emulsions that could potentially actually increase inflammation as well as infection. Now that we know we want to give nutrition early, as well as and we want to feed it preferably enterally, how much should we deliver? So very commonly, we actually use predictive equations such as the Harris-Benedict equation, UPenn, or simply just 25 kilocalories per kg per day. But we do need to remember that in trauma, or at least patients with trauma, the degree of hypermetabolism is actually highly variable. And we also need to take into effects of drugs that we give them. So for example, sedatives that can actually reduce the metabolic rate. So both the European as well as the American guidelines actually recommend using indirect calorimetry to determine the energy requirements for these patients. So this was actually a retrospective study that compared the measured resting energy expenditure using indirect calorimetry compared to using equations. This is done in obese, trauma, and burns patients. And we can actually see that the predictive equations mostly underpredicted the energy requirements of these trauma and burns patients. And again, if we look to the left on this slide, this actually shows us the factors that can actually affect accuracy of caloric requirement estimates based on weight-based equations. And we can see that trauma patients as well as burns patients and even patients with malnutrition are actually within this group of patients who will possibly benefit from using an indirect calorimetry. However, with indirect calorimetry, we also need to know its limitations and its factors that can affect its accuracy. So an important one is like in leaking chest tube, where there are air leaks, which can affect the ability to collect all the expired gases. Other things are if patients are on very high mechanical ventilation, such as FiO2 more than 60 or P more than 12, which can affect the accuracy of the indirect calorimetry as well. Does the use of indirect calorimetry really translate into an outcome difference then? Let's look at some of the studies. So in this study, which is the EAT ICU trial, it actually wanted to look at early goal-directed nutrition using indirect calorimetry as well as titration by dietitian versus standard care in adult intensive care. This is done in Denmark, and in the standard care group, they actually use a weight-based calculation of 25 kilocalories per kg per day. And the outcome they wanted to look at was physical quality of life at 6 months. So the parenteral nutrition group was supplemented, parenteral nutrition was actually supplemented in the study group, while parenteral nutrition was only supplemented on day 7 in the control group. And we can see that in the early goal-directed nutrition group, more of the patients actually met the targets compared to the standard care group. However, this actually did not translate into any outcome difference between the groups. So there was no improved physical quality of life at 6 months, and it did not affect any other secondary outcomes as well, such as mortality, new organ failures, as well as nosocomial infections. So this was another study, a small one, which was a pilot study that also wanted to look at indirect calorimetry versus standard care. The outcome they wanted to look at in this study was actually phase angle from bioelectrical impedance analysis as a parameter for malnutrition. So we can see again that in the indirect calorimetry group, the energy that was provided was actually nearer to the goal. And actually, this is interesting because the energy that was calculated by indirect calorimetry is actually lower than that of the equation using a predictive equation. So the outcome for this study showed that in the standard care group, there was actually a fall in phase angle, which actually suggests that there may be some degree of malnutrition in the standard care group compared to the indirect calorimetry group. So I would say that if there is indirect calorimetry, it is good to use, especially in patients with trauma. If it is not available, then predictive equations can be used as well, but the most important is to ensure that nutrition is actually delivered to meet target set. So other than providing sufficient calories, we also need to provide sufficient protein to mitigate the effects of catabolism. And the American as well as the European guidelines actually suggest a protein dose of 1.2 to 2 grams per kg per day. There have been observational studies that suggest higher protein provision has been associated with improved survival. However, the randomized controlled trials done to compare high versus low protein in critical illness did not actually show any benefit. So Doi et al. In 2015 actually wanted to compare high amino acid dosing versus standard care, whether it could actually preserve kidney function. And they actually did not find any outcome or impact on renal dysfunction. They actually tried to compare 100 grams per kg, 100 grams per day of amino acid versus standard dose. Ferry in 2015 also wanted to determine whether higher amino acid results in higher hand grip strength at discharge. And again, they found that grip strength at 7 days was actually better, but at discharge, there was no difference. But in this study, the difference between the amino acids that were given to the patients between the study group and the control group was actually not much difference, 0.9 grams per kg versus 1.1 grams per kg. And so now that we know how much to give, should we start slow? What is the goal rate that we want to start at? So looking at this trial, which is the PERMIT trial, it actually compared permissive underfeeding versus standard care in about 900 patients. The patients in the underfeeding group received about 40 to 60% of the requirements calculated by equation. The underfed group had lower calories, but the amount of protein delivered was about the same, and they actually had lower fluid delivered to them. So there was actually no difference in terms of mortality or other outcomes in this study. And so patients who are being underfed, the outcome is actually not inferior to patients who receive standard enteral feeding. Okay, and if let's say our patients actually can't meet targets, should we supplement them with parenteral nutrition then? So this was a Swiss study that was done to compare enteral nutrition versus patients without enteral nutrition with supplemental parenteral nutrition versus patients without supplemental parenteral nutrition. The study group actually received supplemental parenteral nutrition for 5 days, with the control group, while the control group actually just had enteral nutrition. The primary outcome that they wanted to look at was actually nosocomial infection. They did find that nosocomial infection was actually lower in the group with the supplemental parenteral nutrition. They also had lower antibiotic days and higher antibiotic-free days. And to note, the overall supplemental parenteral nutrition group actually had a cumulative energy balance of positive 124 kilocalories, while the enteral nutrition group actually was in a negative balance of negative 2,317 kilocalories. So this was another study that compared early versus late parenteral nutrition. This is the panic study. They wanted to look at early supplemental parenteral nutrition within 3 days from day 3 versus late supplemental parental nutrition from day 8. And they found that withholding of parental nutrition until day 8 was actually associated with fewer ICU stay, a shorter ICU stay, shorter duration of mechanical ventilation, and a shorter course of renal replacement therapy. However, this study was actually done in mostly post-cardiac surgery patients, so that kind of limits the applicability of the study results. Finally, we'll touch a little on immunonutrition. So immunomodulating agents include glutamine, omega-3 fatty acids, arginine, and antioxidants. Glutamine itself is actually a fuel in rapidly proliferating cells, and its levels have been shown to decline during critical illness. So it's been postulated to modulate inflammatory as well as oxidative stress response. However, we look at this systematic review by Zenton et al. In 2015. There was actually no mortality benefit for the general ICU population by giving glutamine. Also, in the trauma patients, there was no benefit, but there was some benefit in giving glutamine in the burns group. And looking at infectious complications, again, there was no benefit in terms of general ICU population, as well as in the trauma subgroup. So to note, the data for ICU nutrition has quite a few limitations. The older studies tend to be smaller. The population is so heterogeneous, so they include patients in medical ICUs, surgical ICUs, trauma, post-surgery patients as well. There have been multiple confounding factors, and at times the intervention duration is quite short, and we don't really know whether its effects on long-term outcome can really be determined. And so in summary, I would say we will need to start early, within 24 to 48 hours, feed enterally, use indirect calorimetry if it is available. We want to deliver adequate protein as well as non-protein calories. Parenteral nutrition can be used if there are contraindications to enteral nutrition and should be considered especially for patients with high nutrition risk. Supplemental parental nutrition can be considered after 7 to 10 days. This is according to guidelines as well. And in summary, I actually quite like this review, how this review article from Brazil described it. So after stabilizing a patient according to ATLS principles, let us not forget the F after A, B, C, D, E, which is to feed the patient. And with that, I thank you for your time.